Welcome. Today we're focusing on a condition that frequently causes diagnostic confusion in acute care, Epiploic Appendagitis. Our goal is straightforward. Give you the high-yield facts you need to recognize Epiploic Appendagitis quickly. We want to help you avoid unnecessary workups, antibiotics, and, importantly, surgery.
It's a fantastic mimic. It often looks just like appendicitis or diverticulitis, these really common, serious conditions. Understanding the nuances is key.
Okay, let's start with the basics then. Anatomy. Remind us, what exactly are these epiploic appendages?
Sure. So imagine these small, fat-filled pouches. They're attached to the outer surface of the colon, hanging off it, essentially. Pedunculated is the term.
Little sacks of fat.
Okay.
And how many are there, roughly? Where do they tend to show up?
Adults usually have between 50 and 100 of them. Size-wise, they're typically, let's say, 0.5 to 5 centimeters long, maybe 1 to 2 centimeters thick. Location is key for diagnosis, as you hinted, most commonly. Sigmoid colon and the cecum.
Ah, sigmoid and cecum. That straight away tells you why it mimics the big ones, doesn't it? Left and right, lower quadrant pain.
Precisely. But before the location, let's talk why they cause pain, what actually happens. The most common trigger is torsion, twisting.
Right, they twist on their little stalk, cutting off their own blood supply?
Exactly. They're pedunculated, so they can twist. That twisting blocks the veins first, leading to congestion, ischemia, and eventually necrosis of the fat. Though it's worth noting, sometimes you can get spontaneous venous thrombosis even without a twist. Same end result, though. Localized fat infarction.
Okay, this is probably the most critical point pathologically. How is this different from something like diverticulitis, especially in that left lower quadrant?
It's a fundamental difference, crucial for management. Diverticulitis is inflammatory, yes, but it's usually driven by infection, maybe a microperforation. Bacteria are involved. EA, on the other hand, is sterile inflammation. It's just fat dying off due to lack of blood flow. There's no infection, no bacteria, no need for antibiotics.
No infection. That's the takeaway. It points straight to just managing symptoms. But okay, let's move to the patient presentation. How do they describe this pain?
It's typically sudden, not usually a gradual thing. Patients often describe it as sharp, very localized. They can often point with one finger right to the spot. And it tends to be constant, not really radiating anywhere.
And location again.
Yeah.
You mentioned 57 to 80% are left lower quadrant. That's prime diverticulitis territory.
It absolutely is. That LAQ presentation is the classic mimic. But, don't forget the significant minority presenting with right lower quadrant pain, looking exactly like appendicitis.
So if the location can fool us, what about systemic signs? Fever, feeling generally unwell.
This is where EA often differentiates itself. Systemic symptoms are usually absent. Patients are typically afebrile. Nausea and vomiting are quite rare. And that classic rebound tenderness you look for in surgical abdomens, usually not there with EA.
So a patient who looks relatively well but is complaining of this intense specific spot of pain.
That's a very common picture. If you see high fever, significant leukocytosis, someone looking toxic, you really need to think beyond EA.
Got it. And who typically gets this? Is there a specific demographic?
It tends to be more common in males, usually in the age range of, say, 30 to 50 years old. And there's often an association with obesity.
Okay, so clinical picture is suggestive, but definitely not definitive. History and exam aren't enough. Where do we go next for confirmation?
You really need imaging. Given how much it mimics surgical emergencies, a CT scan is the way to go. It's considered the gold standard for diagnosis.
Before we get to the CT findings, what about labs? What do we expect, or maybe not expect, to see?
Labs are often remarkably normal. You might occasionally see a slight bump in the C-reactive protein or maybe a borderline white blood cell count, but you won't typically see the significant leukocytosis that you'd expect with acute diverticulitis or appendicitis. Normal labs with severe focal pain should definitely make you consider EA.
All right, the CT scan. This is where we can really nail the diagnosis. What are the specific pathognomonic signs we need to recognize?
You're looking for a characteristic cluster of findings. First, an oval-shaped lesion right next to the colon wall. It'll have fat density on the scan. Size is usually around 2 to 3 centimeters. Second, it's surrounded by inflammation.
Inflammation showing up how?
As a hyperattenuating ring. Basically a bright ring of inflamed fat surrounding that central oval fatty lesion. The body's trying to wall it off.
Okay, oval fat lesion, inflammatory ring. What's the final definitive sign? The one that really clinches it?
That's the central dot sign. It's a small, high attenuation dot, like a tiny bright spot right in the middle of the oval lesion. That dot represents the thrombosed blood vessel within the appendage's stalk. See that combo oval fat lesion, ring, central dot, and you've got EA?
Very clear visual. And just as important, what should not be there on the CT? What helps rule out the mimics?
Good point. You shouldn't see significant thickening of the adjacent colon wall. That points more towards diverticulitis or maybe IBD. And critically, you shouldn't see significant free fluid or any free air, pneumoperitoneum. Seeing the classic EA signs without those other concerning features really solidifies the diagnosis.
Okay, diagnosis confirmed by CT. Now let's quickly run through the main conditions we need to differentiate this from. The big three mimics.
Right, it's all about location. Right, lower quadrant pain. The top mimic is acute appendicitis. Similar pain, but appendicitis usually brings fever, maybe vomiting, and that elevated white count, left lower quadrant pain. Sigmoid diverticulitis is the main concern. Again, look for fever, higher white count, and the CT will show diverticula and usually more definite bowel wall thickening.
And the third one, often forgotten, but pathologically similar.
Omental infarction. It's also fat necrosis, but the lesions in omental infarction tend to be larger, maybe less clearly defined, and not typically attached right to the colon wall in that characteristic way in epiploic appendages.
Makes sense. So the CT confirms it's EA. Treatment strategy immediately shifts, right? What's the standard approach?
Absolutely. Management is conservative. That's the key message. This isn't a surgical problem. It's not an infectious one. Treatment is purely supportive. Time and symptom control.
And symptom control means what medications specifically?
Right.
And what do we avoid?
Primarily, nonsteroidal anti-inflammatory drugs. They target both the pain and the underlying sterile inflammation. Simple analgesics can help too. What you absolutely must avoid, or rather withhold, are antibiotics. Giving antibiotics for sterile fat necrosis is unnecessary, carries risks, and contributes to resistance. It's crucial to stop them if they were started empirically.
And what can we tell the patient about recovery? They're in pain, probably worried.
You can offer very strong reassurance. The prognosis is excellent. The pain, although it can be quite intense initially, resolves relatively quickly. Most patients feel significantly better within, say, 3 to 14 days. And recurrence is very, very rare. For most people, this is a one-off event.
Let's bring this home. Thinking about the healthcare system, patient safety, what's the biggest danger in missing this diagnosis?
The danger is overtreatment, plain and simple. So wrapping that part up, EA is acute abdominal pain, often severe and focal, but typically without the systemic signs of infection or sepsis. The CT findings, especially that central dot sign, are key to confirming it and allowing for simple symptomatic management.
Right. EA is one of those diagnoses where recognizing it actually prevents invasive treatment. So here's a final thought for you, the provider listening. We know that acute localized abdominal pain sets off alarm bells for surgery. When the patient lacks fever, has normal or near normal labs, and doesn't appear septic, how can we potentially adjust our protocols or thinking? Could we prioritize getting that definitive CT scan earlier in these specific cases, rather than defaulting immediately to surgical consults or broad-spectrum antibiotics? Something to consider in your own practice. Optimizing that decision point could save resources, reduce antibiotic use, and spare patients unnecessary interventions.